individuals that are joining us today. I think that we have had some additional interest because we have our guest presenter that is going to be discussing pediatric eating disorders. So we are going to go ahead and begin with the first part of our ECHO. As I mentioned, their mission of ECHO is to enhance providers' knowledge, and we do so through two mechanisms, didactic PowerPoints as well as case presentations. We are going to begin with the first part of our ECHO clinic today with our didactic that is presented by Dr. Melissa Gonzalez. You did a wonderful job introducing yourself, but I'd love to just do a brief bio if that's okay. As she mentioned, she's a faculty member in the Behavioral Psychology Department and a behavior analyst in the Pediatric Eating Disorders Program. She's an assistant professor in the Department of Psychiatry and Behavioral Science at the Johns Hopkins University School of Medicine. Dr. Gonzalez's training and research have focused on the behavioral assessment and treatment of skill deficits and behavioral excesses in individuals with developmental disabilities. And her current research interests include the behavior analytic assessment and treatment of pediatric food refusal and co-occurring behavioral excesses occurring both in and outside of meal context, skill acquisition, and related caregiver training. So we will go ahead and begin with her presentation today.
Okay, well, thank you so much for having me. I'm really excited to share this information with the group. I really struggled to fit in everything within 25 minutes. So there's going to be some parts of the presentation that I may go over a little bit more quickly than others, just so that we can attempt to leave some time for questions at the end. Okay. So, I really just wanted to first start out by giving a little bit of background about how our profession defines pediatric feeding disorders. Within the DSM-5, the most recent version, it's actually a new diagnosis, avoidant restricted food intake disorder. And I just wanted to point this out so that we can kind of distinguish between picky eating and what we would actually define as a pediatric feeding disorder. The hallmark features is that you typically do see some weight loss or failure to meet appropriate weight gain. In individuals with autism, we actually often see obesity. So we see those children, we do see some children who are losing weight, but we also see the other end of the spectrum where they're only eating really high fat, high carb foods. And so therefore, you can also see this manifested in a way where the child's actually overweight and only eating unhealthy foods. Again, we do see some nutritional deficiencies based on the children's diet, either not eating enough or maybe eating the wrong types of foods. There are many children that are dependent on enteral feedings or on formulas or calorie booster drinks to maintain their nutrition or their calories. And then certainly some interference with psychosocial functioning, where families' entire day is really focused on trying to make sure that the children are getting in the foods that they need, and meals can be very stressful and can also have a really big impact on their ability to socialize within the community and also participate in socially significant activities. So in terms of eating disorders within autism spectrum population, we really see that the types of feeding problems within children with ASD are also very similar to the types of feeding problems that we see in children without autism. And so we're seeing it manifest in a very similar way. The key difference is that we see it happen a lot more frequently with children with autism. There are some studies that have indicated that it's happening almost 5 times as more likely in children with autism relative to typically developing peers. And some of the prevalence of feeding problems is estimated to be as high as 90% of children within the autism spectrum population. One thing that's tricky, I think, for parents and for professionals is that the cause isn't always apparent. And so for many children that may have more of a medically complicated background, it's often we can often point to an early medical complication or an allergy or reflux that makes it kind of make sense of why they may be having this difficulty with eating. With children with autism, that isn't always there. And, I think the number one stressing factor that parents come to us with is, but why are they having these difficulties? My child didn't have a lot of early medical complications. They don't have allergies. They don't have reflux that we are aware of. And so, really being able to point to what was that impetus of the feeding problem is sometimes more difficult to identify for children with autism. There isn't a single event that parents can point to, and I think sometimes that can be really stressful for parents and to be able to kind of get a good understanding of how to approach the feeding problem. We often see that children will add or eliminate foods over time, and sometimes it's a little difficult to anticipate when that's going to happen. So, we may see that all of a sudden they're eating only Chex cereal, and they'll eat Chex cereal and basically live off of Chex cereal, and then a week later, all of a sudden they don't want Chex cereal anymore and they may be on to another food. And as you might imagine, this can be very stressful for parents because they may be spending a lot of time really making sure that they have the 1 or 2 foods that their child will consistently eat, and then all of a sudden the child no longer eats those foods. And so they're having this, start over from scratch. Oh goodness, what are we going to provide him or her now? There is some research looking at longitudinally over 20 months that the selectivity of children with autism doesn't necessarily improve over time. And anecdotally, I can say that we also see that within our clinic is that that while the selectivity of what the child may choose to eat may change over time, but the fact that they're only eating 1 or 2 foods or a very select number of foods, that doesn't change over time without intervention. And I think another thing that's really important to highlight is, caregivers, this can be very stressful for caregivers and for families overall. And there are many studies to point that caregivers endorse higher levels of stress and behavioral difficulties in children with autism with feeding problems compared to children with autism without feeding problems. And so having this added area of challenge really may increase the overall stress level and also kind of how they perceive the overall presentation of their child. So, I think I really wanted to point these out just to kind of highlight the social significance of these problems, that it's not only impacting what's going on during the meals itself, but also, can impact how they're interacting with their children over time and how they kind of perceive their child's development and their difficulties. So a quick word about the etiology of feeding problems. This is something that I could probably spend 20 minutes talking about alone, but given the time constraints, I'm just going to touch on it very briefly. Oftentimes in the general population, we see that there is a medical component that may be the impetus of the feeding problem. And as I said, with children with autism, we may not necessarily see that, but there may be some aversive pairing of eating certain types of food or eating in general is not a pleasurable experience. And so therefore, they're very selective about what foods they may eat. We'll talk a little bit about what food selectivity is in general in a couple of minutes. But overall, there's this, eating isn't necessarily a pleasurable activity. And because of this results in lack of practice of eating, and so they're not necessarily gaining the skills that are necessary to be able to eat a wide variety of foods. And then with this, there's also this learned behavioral interaction of escape and avoiding foods in general or certain types of foods. So let's focus a little bit more on food selectivity. Now, while, different types, as we mentioned before, there's different types of feeding problems that may be presented by children with autism, food selectivity is probably one of the most common, so that's what I'm really going to gear the rest of this presentation to. Although if you have other questions about, children who are failure to gain weight or liquid dependent or, things like that, we can certainly talk about that as well. So food selectivity can really come in various forms. Their children might be selective by the type of food, so maybe they'll only eat bread type foods or high carb foods. They may be selective by the color of foods. So I will only eat orange foods, so Doritos and carrots are good. Anything other than orange foods, I'm not going to touch. It's not something that they're going to consider eating. We also see a fair number of children who are very brand selective. And so not only will they only eat chicken nuggets, but they will only eat chicken nuggets from McDonald's when they're warm. Reheated chicken nuggets will not work. And so here you see parents who are really going to great lengths to make sure that the food that their child is willing to eat is available. I've seen many families who said, well, my child will only eat Udi's brand pizza, and so they have a refrigerator stocked of Udi brand pizza ready to take out at a moment's notice. So you can imagine the financial burden that this might present, as well as kind of the stress of making sure that you have that single food on hand. Also texture. So we see a lot of children who are texture selective, meaning that they will only eat certain types of foods of texture. So maybe they will only eat soft foods like a yogurt or an applesauce, but won't eat anything that would require higher chewing skills, or vice versa. Maybe they are averse to more of those softer foods, but they will only eat really crunchy textures. Now this might have something to do with the child's preferences, but it may also have something to do with the skills that the child has and their ability to actually manipulate these foods in an effective manner. Also, we see children that are pretty rigid about how the food must be presented. So if there's crust on the pizza, they won't touch it, or if there's a bruise on the fruit, it's not going to happen. It has to be perfectly cut in a certain shape for the child to eat it. So these are all the different types of food selectivity that we may see. Now, in terms of the behavioral history, I think it's really important to emphasize that, once a child is selective about a particular type of food, not only are they limiting what their diet is, but they're also limiting what their future practice is in order to be able to efficiently manage other types of food. So children, start out eating lower textured foods, and as foods are introduced, they're gaining the oromotor skills to be able to effectively manage higher texture foods. Well, if children are selective, they're missing out on some of that practice and exposure. And so this will lead to skill deficits. And so, while children may be selective because it's not a food that's within their preference, they may also not have the skills that they need in order to effectively manage that. And this can only go on to reinforce their strong preferences for certain types of foods. So you have sort of a loop that starts to develop over time. So we're going to touch briefly on some empirically supported treatments. Again, I'm going to go through this pretty quickly in an attempt to leave some time for questions. So what do we know? We know that there's multiple factors involved. So, there may be some underlying medical issues. There may be some skill development issues that are impacting their selectivity. And there's certainly some learning that's occurred over time. It does have a significant impact on the family and individual functioning. And luckily, behavior analytic treatments can be very effective. The key part, and one part that I'm really going to spend some time to talk about, is, hold on one second, sorry guys. One part that I'm going to, one part that I'm really going to focus on is that the necessity of often having other people that you're consulting with whenever you are working with children with feeding problems. Because it is a multi-component problem, and there's lots of different things that could be going on to kind of intersect to make this feeding problem, it's really important that you are consulting with other disciplines and making sure that you have all the expertise and resources available to you to be able to really be effective at treating the problem and making sure that you are not exacerbating an issue that may be underlying the feeding problem. Okay, so the behavior analytic treatment, we're really going to be focusing on identifying and manipulating environmental variables to increase the appropriate behavior and decrease inappropriate behavior. Again, we're going to be looking at antecedents, behaviors, and consequences to the refusal or to bite acceptance. We're also going to be really looking at what's going on in the environment. So are there certain types of interaction or attention that's from others that's occurring when the child refuses the food? Are they getting access to particular preferred activities or toys when there's refusal? Could there potentially be some use of these activities and toys that actually may make the meals more pleasant and something that may be make the child more willing to participate? And also, how is the demand presented in terms of the presentation of the food or the removal of the food, and how might this impact the child's appropriate behavior and inappropriate behavior? Based on the research, we do know that food refusal is often maintained by multiple variables. That being said, escape is really common in terms of being one of those variables maintaining refusal. Here I'm citing some of the percentages from the Piazza 2003 article, but there's been multiple studies indicating that escape is often a maintaining factor and escape extinction is often an effective treatment. So escape extinction has been repeatedly documented to be effective, and basically what we're looking at is the child will refuse during meals, and this often leads to the removal of the food, and what the treatment's going to focus on is that refusal no longer results in the removal of food, the food remains, and that taking a bite or doing something that's appropriate within the meal results in the removal of the food. And that's really kind of the basis of escape extinction, of what the treatment is going to be working towards. We also have noted in the literature that contingent access to attentions, toys, or activities may help decrease the level of refusal or crying, but it may not be sufficient alone. So there's been many studies to indicate that while having access to attention and toys and activities is helpful in kind of reducing the level of distress during the meal, it may not necessarily be enough to actually get the child to accept that bite. So, you know, while escape extinction is very effective and we're really good at increasing food acceptance, there are some things to note in that the approach may not always be very practical. I'm going to show you a quick video here just to highlight this.
Can you hear me?
Yeah, I'm not sure if you guys were able to see that, but hopefully you were able to hear it. And if not, I can briefly describe what it was. Basically, it's, you know, a child who's being presented milk, and all of a sudden they're, you know, huge tantrum, running away from the table, climbing out of the chair. You know, it's as if monsters had just come into the room. You know, a glass of milk was really that difficult for that child. So, you know, given the extinction burst that one might meet when doing escape extinction, it's really important that you take in consideration some of the factors before you decide to intervene. And I'm going to kind of note some of those now and go into more detail. So there's lots of areas to consider before intervening, and these are particularly important in the realm of feeding problems because there's lots of areas that one might not be able to detect readily that may be impacting the child's food refusal. And so it's really important as behavior analysts that we're making sure that we have all of these areas considered prior to intervening, and particularly prior to attempting any type of escape extinction. In terms of getting an information of kind of where the child is, you're going to want to get a pretty thorough developmental and medical history to see if there's potentially may highlight any medical issues that may be ongoing. We'll typically start out by getting an intake log from anywhere from 24 to 72 hours. We want to get a sense of what the variety of the food that the child is eating and what is being offered. You know, I think sometimes parents can be hyper-focused or kind of anxious about what's being presented to their child and what their child may be eating. And developmentally, there is some typical pickiness that children go through, and I think it's important to get a good sense of what's going on to be able to differentiate that from what we would call more it being disordered feeding. Typically want to start out with a meal observation, and that's not only including the child eating what they're willing to eat, but also some non-preferred foods. And one really important thing with this is we're going to be identifying antecedents and consequences to either bite acceptance or refusal, but also just looking to see how is the child managing that. You know, do they seem like they're choking a lot? Or are they coughing? Are they swallowing whole? You know, some of these things that you could see through meal observation can really highlight the necessity to maybe contact some of your colleagues in another area and get some consultation. And so I think really getting a good sense of what the meal looks like from the beginning is really important. Also looking at typical meal duration, having an idea of what the setting and structure is. You know, is the child grazing all during the day? Are they sitting at a table and chair? And there's also a number of available indirect measures that can kind of also highlight some of the behaviors that might be need to be addressed during intervention, some of the skills, and also getting a sense of how restricted is the child's diet at this point in time. So I have those listed there. So in terms of medical and nutritional status, it's really important that that you collaborate with other professionals. So if you haven't already heard that part, here it is again. I'm saying that it's really important that we're ensuring medical stability and safety prior to intervening. And the reason that is there's lots of medical issues that are associated with children with feeding problems, and some of these things may have gone undiagnosed, and your treatment outcome is not going to be optimal if you aren't able to diagnose in the underlying or treat in the underlying medical issues. Reflux is one that we see very common for children who are having complete food refusal or only drinking. Reflux, we see that up to about 90% of children with G-tube dependence. So for those kids that are dependent on more of a formula or tube dependence, reflux is something that is frequently seen and maybe have gone undiagnosed. Given the children with autism, they may have impaired communication and may not be able to communicate effectively that they're in pain. This is something that you definitely want to make sure has been ruled out prior to intervening. Also, eosinophil esophagitis is a type of allergy, but it's not an allergy where you would see an immediate reaction to food. So it's something that can be underlying the feeding problem, but be hard to detect. And so that's another one that you would want the child's pediatrician or another consulting medical professional to make sure that that's ruled out prior to intervening. Also, we want to make sure that the child is safe for swallowing, particularly for some of the children who have multiple areas of developmental delays. We want to make sure that they are safe to swallow and they're not at risk for aspiration. So if you have a child who's had a medical history that includes pneumonia or multiple pneumonias, that's going to be something that you're going to want to make sure it has been ruled out as a complicating factor. Also, we're going to want to make sure that anatomically everything is where it needs to be. And so that's where some of those meal observations that you're going to be doing or looking at the child's medical history will really may give you some red flags, and that's when you're going to want to consult with another professional to make sure that there's not anything anatomically that may be impacting the child's ability to eat certain types of food. It's really important that you also inquire about body mass index. So what is the child's weight for height and where they are compared to their peers. You're going to want to also ask, very important, how does the child get in fluids and how consistent are they with that? Okay, we've seen many children who are very selective and may not always be able to consistently get in the fluid that they need, and that's going to be something that's going to be really important that you identify what methods are in place for that prior to intervening, because if a child stops drinking while you're intervening on, maybe one area of their feeding, it might start to impact other areas of their feeding, and if they're already limited in how they get in their liquids, that can very quickly turn into an emergency situation where the child would have to be sent to the ER to be able to make sure that they're not dehydrated. And so making sure that the child has a very clear, consistent method to be hydrated is important. Also constipation, so that if the child is not getting the hydration that they need, it can also result in constipation, and having constipation could result in them not wanting to eat. So these are all issues that you're going to want to make sure that you ask about and have a good handle on prior to intervening. In terms of their skills and experience, you're going to want to make sure that they are safe to swallow, as I mentioned earlier. Have an idea of, how are they getting in their fluids? Do they have safe cup drinking skills? Are they able to clear a spoon efficiently? Where is their self-feeding, and what would be an appropriate expectation for that particular child? And also, where are they with their chewing? As we mentioned. Sorry about this, guys. As we mentioned before, given that some of the children may not have had lots of experience eating, they may not have necessarily developed all the skills necessary to chew. And so you're going to want to look to see, is there a lot of gagging, coughing, vomiting? Or do they tend to eat well in the beginning of the meal and then stop eating? Could there potentially be a strength and endurance issue? Are they able to move their tongue in the way that makes chewing foods effective? And so these are all areas that would have to be considered if texture is something that may be the presenting problem. So, one word of caution: if intake is limited to only one source of calories or one source of fluids, consider the potential risk of intervention. One thing that our clinic team always considers is if they're only drinking, let's say, Capri Sun, and we start to try to intervene and have them start to drink milk, what would happen if they stop drinking Capri Sun? What is our backup plan? And so always keep in mind, if you're seeing a child that's very selective and that they're only eating one food or only taking one drink, have that backup plan, or consider what would happen if they stop taking in that one source of calories or fluid, and having a very frank conversation with the family about that. And considering, okay, am I in a service level to where I can intervene in this, or is this something that I'm going to have to coordinate or refer out to someone else who has the resources to be able to manage that? Prioritizing goals is also something that's going to have to be considered prior to intervention. Sometimes sometimes parents want their children to be able to eat an age-appropriate diet of, my child is 7, they only drink Pediasure, I want them to chew chicken nuggets. Well, consider what is their total calorie intake, and is it realistic for us to be able to have them eat chicken nuggets? Maybe we want to get in some other foods in there to be able to increase their caloric intake that don't require all the skills of chewing like chicken nuggets. So there's going to be trade-offs there, and that's something that you're also going to have to make sure to have a clear discussion with families, understanding what are their priorities and what would be the best way for us to intervene to make sure that the child is getting their needs met. Again, also considering what's going to be socially relevant for the family and feasible. So these are all some things that need to be considered prior to intervention, and making sure that the family and the clinician are on the same page about where they want to see this child go, and what might be in the best interest of the child nutritionally and medically. So, I think prior to intervening, it's going to be really important that you have sufficient training of staff, that they're able to ask the right questions, and also have the particular skill set needed to be able to support the child and the family. And also making sure that caregivers are sufficiently trained to be able to manage that extinction burst if that's something that's part of the intervention, and that they have a plan to be able to deal with that. I think, also collaboration with other professionals within the community is going to be really important. I think having a good relationship with the child's pediatrician can go a long way, and they're often someone who can provide some consultation in some of these areas that may not be your area of expertise, but you could have these conversations of saying, hey, is there any possibility that reflux might be going on here? Or, hey, do you think he's getting in enough fluid? How much food do you think he needs at this age? And it can really be a powerful partner in terms of intervening. And finally, also knowing when to refer out to other disciplines for either a rule out, for support, or, in the case of when a child is very selective and only has one source of calorie intake, if you're not in a position to where you want to kind of make that risk of, well, if they eliminate this food, what am I going to do? Maybe knowing when to refer out to maybe a more intensive program. Also, managing caregivers' expectations. As we've hit on a little bit earlier, this is something that can be very stressful for families, and so it's important to consider how caregivers can manage refusal at home. If this is something that they're going to be maybe doing once a week in a clinic and then practicing at home, really having a good plan to where this is something that the parents can be consistent with. We also often see that as we're intervening in meals, we may also start to see an increase in other types of problem behavior simultaneously. And so this is something that you might want to talk with families up front. As we are providing more structure within meals or taking away some of the control that the children have in meals, you might start to see problem behaviors in other areas. For instance, as we decrease the child's refusal within the meal routine, we might start to see an increased refusal during the nighttime routine or some other type of routine within their day. And so letting them know that oftentimes these changes might be temporary, but it may be also important to note that it's going to happen, and that it's an area that you might also need to be asking about with the family, and be ready to provide support with as well. Okay, so let's get to some of the strategies. Now that I've told you all the things to watch out for, let's go ahead and talk about where to start. So I think, a good place to start is doing a functional assessment. And as we've noted before, really starting out with a structured meal observation. With this, you're going to be looking to identify antecedents and consequences to refusal, and also maybe getting a preference assessment of what the child would be willing to eat. The preference assessment in itself may reveal some patterns that maybe the parent wasn't able to detect, like, okay, this child's only eating dissolvable crunchy foods. They're not eating anything that requires more skills in chewing. Maybe there is a skill deficit there that I need to be aware of. Or this child's only choosing very low texture foods, oatmeal, applesauce, yogurt, and they're not choosing these other foods. That may, give you some good information about what may be going on, and also where to start your intervention. A good place to start as well might just be to provide some structure to the meal. Oftentimes, children and parents really start to find meals to be very kind of aversive situations and stressful situations. And the parent may just say, okay, I'm not going to ask them to eat anything anyway. I'm just going to give them their goldfish and let them go. Or I'm going to give them their Udi pizza and let them go. And so there may have been a long period of time since the child's actually been asked to eat anything that might be less preferred. And so, part of your functional assessment might be just providing a little structure within the meal to see how does the child respond, and maybe provide some groundwork for how to start to provide some structure during the meal. Again, functional analysis of inappropriate mealtime behavior, that's something that we do routinely within our clinic. I would recommend that you read this article. It may not be feasible for all settings, but can be very helpful in identifying what variables are maintaining the child's refusal. Okay, some antecedent considerations. A big one to consider or to ask is, when is the child eating and drinking? Are they grazing throughout the whole day? The first thing that you're going to want to do is cut down on the grazing. Because that can actually decrease the child's motivation to eat when you are setting a mealtime. And so one antecedent consideration to talk with the families to say, okay, can we just try to structure the meal opportunities where the child has maybe 3 meals a day and a snack or 2 snacks, depending on their age and kind of what their baseline schedule is. But really trying to cut down on that grazing can go a long way, and that it might actually increase the child's motivation to eat when you do present that meal. And so that is a very good place to get started. Also, talking to the parents about how much is offered. If a whole lot of food is offered, the child may be less willing to eat it, So really considering how much food is offered, and also starting small. So if food is offered that the child is going to be less likely to eat, maybe reducing the amount of that food, and see if some of these antecedent manipulations can be enough to have the child willing to try some foods. Where is he or she sitting? A lot of children just walk around throughout the meal, and providing some structure around the meal can go a really long way. And so starting a point of intervention might be, okay, let's just have him start sitting at a table and chair during set periods of times a day, even with their preferred food. Let's just have them start sitting at the table and chair. Providing that structure can be a very effective point of intervention where the child is attending to the stimuli that you want them to eat. And you can also provide some consequences for trying a food. You take one bite and then you get away from the table. If the child is kind of roaming around and grazing and kind of moving around throughout the meal time, then it's hard to kind of harness that motivation to eat and be done and leave. So that could also be an effective place to get started. A lot of parents report that it's just hard to even get the child to come to the table. So, a big point of intervention might be, well, what is the child doing right before the meal? Well, having that child transition from a highly preferred activity, playing my video game, to going to the table to eat this really, really low preference activity might be a hard transition, right? So how can we make that transition easier? We could either put a moderately preferred activity prior to the meal, or have the child transition to the table with a highly preferred activity, and then maybe go to a moderately preferred activity at the table and then eat, and starting out with small increments. How long do meals last? Ideally, we're looking for meals to last anywhere from 20 to 30 minutes. It's very common for parents to say, oh, the meals are taking 2 hours, or I feel like I'm feeding them all day long because I just want to make sure they're getting the food in. And so really keeping an eye on the meal duration and thinking about ways that you can make the meals more efficient. Some consequent considerations. How to end the meals, right? So if you're going to come up with an intervention to target the food selectivity, it's important to have a termination point, a way for the meal to end. No one will be happy after struggling at the table for hours and hours on end. And so we often recommend ending the meal based on time rather than refusal. therefore, the child comes to understand that I'm going to have to be here for a set period of time anyway, and it's not based on me refusing. So that may actually decrease the level of refusal or the level of active refusal that you're seeing during the meal, and may just kind of take down the stress of the meal. It also gives the parents a way out, right? So, okay, I just have to do this for 5 minutes or, 2 minutes. And that way you're able to kind of establish a routine that maybe both the child and the parent can both follow through with. Also, considering how is that child and caregiver interacting? Is there lots of discussion about food or this, come on, please eat the peaches, please eat the peaches. I know you're going to love them. We typically recommend that the topic of conversation during meals is not related to food, and that we really try to decrease the amount of coaxing that may go on during the meal. And I think really also planning how do you want the parents to respond to refusal when the child is at the table. One way to do that, again, is to set that timer and say, okay, the meal's only going to end when the timer beeps. It's not mom. It's not the more you hit doesn't mean the quicker you get away from the table. It's when the timer beeps. And sometimes that, as an intervention, can be very powerful. Here I have a little cartoon talking a little bit about reinforcement, and here Toby says is making an annoying noise. Dad says, "Oh, don't do that. I find that annoying," and then all of a sudden it increases. I think really considering and giving the parents some education beforehand how their interactions with their child related to food or related to what the child's doing at the table can actually exacerbate that situation or keep it neutral. And we're really focusing on keeping it neutral and having it be time limited. So overall, the goals of intervention is to increase exposure without escape or avoidance, minimize refusal, avoidance, or distress during the meal. This is going to be helpful for both the child and the parent. Program external rewards or reinforcement, and sometimes parents are a little put off by that. They say, well, do I really have to reward my child for eating? Shouldn't they want to eat? Well, for many of these kids, eating is not as pleasurable as it is for you or I, right? There's a aversive pairing there, whether it be related to all foods or specific types of foods. And so at least initially, you're going to need those external rewards to get the child to respond. And I would recommend that you first target acceptance, and after you get the child accepting the food, then work on some of these more independent skills. But really prioritizing the goals there. Asking the child to stab the piece of peach and put it in their mouth, chew it and swallow it might be a whole lot. Whereas if I just ask you to take it off the fork, that might be something that the child might be more willing to do with providing a little bit more guidance and structure. And also programming for generalization, another area to consider as you're planning. So I'm going to end this with top 10 practical strategies, and I hope that you guys can find it helpful. And unfortunately, I'm not sure how I'm doing on time. I hope I'm doing okay. So here we go. Introduce, anytime you're working with introducing new foods or foods that are that maybe the child is less likely to eat, a very good practical strategy would be to do those separate from the full meals. And the reason that is because if the child is already limited in their intake, you don't want your introduction of new foods to impact what they're already eating. Right? And so one practical strategy might be just to try to divorce those two or keep them separate. Also, if you work on practicing new foods with the foods that they're already consuming, you might see that they're going to be less likely to want to consume the foods that they typically eat. And so this is just a really good strategy. What we often do is say, okay, eat your regular 3 meals during the day, and then just have 1 snack time or maybe 2 snack times during the day that's totally separate from the meals. That's maybe 10 or 15 minutes where you're doing practice snacks, okay? Start small. So if your child, if the child is going to be working on eating fruits, start by only having the child take a very, very small bite of the fruit, and then gradually build up what is going to be expected of them over time. So one good example of this, I don't know if you guys have seen this, but whole roasted crickets apparently is it's a big new thing on the market. I went to Mom's the other day and found this. And I'm a pretty adventurous eater, but I think I would have a hard time eating a whole bag of crickets, right? But if you gave them to me on a chip and it was only one little piece of cricket, I might consider it, right? And so think about when you're introducing these foods to your clients, that it might as well be crickets to them, right? So start out with a very, very small amount, ask them to eat it, get some consistency with that, and then build up from there. So demand fading goes a really long way. Set clear expectations and incentives for rewards, and be sure to reassess the effectiveness of the rewards frequently and program strategically to maintain their value. If this is something that the children are going to be practicing every day or multiple times a day, you're going to want to make sure that there's some motivation for them to continue to practice this. Set specific parameters of how and when the task should be completed. It's not uncommon for a child to be seen in our clinic, and you know, the first concern is, well, they won't let any new foods in their mouth. Well, we can eventually get them to put the food in their mouth, but then they don't chew or swallow it, right? And so the target of intervention within eating in itself might shift, right? So it's going to be really important that you're setting really clear parameters of what should be done. You're also going to want to practice repeatedly and increase the amount of foods that are required gradually over time. Incorporate choice. We found that choice often can be really effective in terms of decreasing the amount of refusal. It may not alone be enough to get the child to actually eat the food, but we often do see that it will decrease the level of refusal. In sessions based on time rather than refusal. Once the practice is over, move on with the daily routine and start fresh at the next practice session. Collect data to determine what strategies are working and when to make changes. And finally, be strategic about what foods are targeted to maximize success and benefit. What I mean by this is you might want to choose foods that are texturally similar to the foods that the child is already eating, or that have some similarities in terms of their flavor or taste, and then to branch from there. All right, so I think I'm probably running a little over. How am I doing?
You know, I think that we are out of time for questions from the audience at this time, unfortunately. But what I wanted to ask you, Dr. Gonzalez, is it okay if we also post these PowerPoints on the website as well?
Sure.
Okay, wonderful. And I wanted to also let everybody in the audience know that we have a link that we post within 2 weeks of the clinic that will actually have this video. So folks can go through and re-watch the video presentation that Dr. Gonzalez just completed and also access the PowerPoints. So those are typically available within 2 weeks of the clinic as well. And then we have some additional resources that we can also add into those folders that everybody can access too. So Dr. Joe Darling is going to actually be presenting on the next phase of our Echo Clinic today, and he's going to be presenting on a couple of case studies. And so what I would love to do before we transition over to him is potentially bring up the piece that I feel was a very a large component of Dr. Gonzalez's presentation today, and get her perspective as well as Dr. Stoll's perspective on that collaboration piece. Because the goal of Project Echo is to work in communities that are often underserved, it's difficult sometimes for providers to identify other collaborators that might have knowledge about working with children with autism. And so I was hoping that from a developmental pediatrician, you could discuss whether a primary care physician in a rural community would be able to collaborate with the behavior analyst in this capacity, and how a behavior analyst could approach that pediatrician.
Yeah, so that's a really important thing for us to think about. And, you know, that was an outstanding presentation, yeah. Dr. Gonzalez. I was really interested to hear what you said, and it's always fascinating for me to think more about this. Certainly, the majority of the kids that I see in clinic are struggling with these issues. The thing that's tricky, when you think about a primary care physician, not only do they have limited experience with children with autism, but when you're trying to evaluate for reflux in a typically developing child, it can be very difficult because essentially symptoms are really vague. So you have to ask things like, you ever have sour burps? So that's like a pretty common way that we ask them, do you ever have sour burps, or does it ever feel icky, like, whatever. But that's a tough concept. And so sour burps are kind of a good way to get sick. That's in typically developing kids, right? And so when you add in autism with varying levels of communication ability, that can become incredibly challenging. So I guess my thought about this is, yes, the interdisciplinary team is essential, but one of the things we kind of talked about was when you ask for the pediatrician to give medical clearance, you might have to coach them a little bit. They may not know what that means. They're very busy, and they may not know. They may say, oh yeah, sure, he's fine. But that doesn't necessarily equate to really he's fine. So I actually made the comment when you had the slide up of the tongue and the oral pharynx anatomy. We are not speech and language pathologists. And so I know one of you is a BCBA and a speech language pathologist. I think it's Angela. And you know that, well, I don't know if you know this or not, but we don't know that stuff. But we don't know the swallowing physiology, and we don't know those kinds of things. So we're not going to be able to clear that. We have tests that we can order. There are barium swallows. There are all kinds of things we can do. But again, at face value, if a kiddo comes in with behavior problems and the question is, are they medically cleared for a feeding program? Odds are they're going to say yes, but that doesn't mean that's altogether true. So as a BCBA and as a member of that team, I would really encourage you to work with them and say, hey, here's what I'm worried about. We've got this little guy, I've done an evaluation, it definitely is behaviorally based, but he's got some other little funny things that I think might be going on. He's nonverbal or he's whatever. And you might have to give them a little help because they're not going to know that. Echo Autism for Primary Care is trying to teach some of those important things, like what to look for, how to evaluate, how to do these things. But still, it only goes so far, and we don't have every single pediatrician in the world doing it yet. And so just remember that your knowledge is as equally important as that pediatrician, and they're going to need you to kind of help them think through some of these things. That's kind of how I think about it, and certainly just want you to recognize that when you ask for that medical clearance, you need to know what that means. It likely means a quick pass off by the nurse with a piece of paper that says, hey, this kid needs to be medically cleared to do some behavior something or other. And we usually are like, oh yeah, I remember that well child check from a year ago, sign, done. So you really just know that. And so you may have to pick up the phone and call and say, I don't know. Just something doesn't feel quite right about this kiddo. Can you see him? Or whatever. So anyway, those are my 2 cents, but I do think it's helpful, hopefully, to know that, because we really, as general pediatricians, really have very limited to none exposure to these kinds of complicated issues in kids with autism.
Thank you. I always love getting your perspective on what knowledge, because I think that oftentimes we go to our physicians and just assume a lot of that piece. And so Dr. Gonzalez, do you have recommendations for behavior analysts when they're approaching, and tools that you would be recommending that they could approach their PCPs with?
I think if this is an area that you're going to go into, or that you're going to see a fair number of patients with, I think really collaborating with your community professionals and forming a relationship, and rather than I think forming a relationship of allies is really, really important. Pediatric GIs are also really great. Again, they may not always know how to read a child with autism, but I think if often a lot of them are looking for your area of expertise, and so if this is an area that you're going to be seeing multiple patients in, I would reach out to a local pediatric GI, or probably a pediatric GI would probably be the way that I would go, and try to form a relationship, even if it's a person that you could just consult with, and that maybe that it's not your patient's doctor, but someone that you could run things by and talk through, that might be able to be a part of the team that can also talk with the pediatrician. I think that would be really important. I feel very fortunate in that I have a GI built in and I have a pediatrician built in, but I think if I was operating solo in the community, that would probably be the first thing that I would do.
Excellent recommendations. Thank you so much, Dr. Gonzalez. I wish that we had more time for a longer presentation, but it's been wonderful having you, and we really appreciate everything that you contributed today as well. And I'm very much looking forward to our case studies for today. As we discussed, we have the didactic presentations and the case studies that we use as learning opportunities for our participants. We have two different types of presentations: cases that are brought for consultation and case studies that we discuss the progression of treatment. Dr. Joe Darling will be discussing the progression of treatment for some adults with disabilities that have demonstrated pica and rumination. And if I may introduce you, Dr. Joseph Darling earned his PhD in psychology from North Central University. He's been practicing as a behavior analyst for nearly 27 years, and so we're very fortunate to have his expertise today. His professional experience is vast, including work in a variety of settings, developmental centers, residential facilities, home and community-based settings. Within his practice, Dr. Darling's behavior analytic interventions have been applied to working with individuals with autism spectrum disorder, intellectual impairment, traumatic brain injury, pica, and multiple comorbidities. Today, he's going to be presenting on the two cases that I just discussed. And as we mentioned, the role of our, or the goal of our ECHO is to create an engaging learning experience. So we will try to incorporate opportunities for the audience to ask questions throughout the case presentation, and then our hub panelists, their primary goal is for us to go ahead and bring back the learning opportunities to the core learning theme of this ECHO, which is to identify and address treatment barriers for families. So we'll be asking questions to help guide that discussion to bring it back to those learning opportunities throughout the process. Dr. Darling, please feel free to begin whenever you are ready to do so.
Hope I have it up right. I'm going to go over a couple of cases, a couple of individuals and the treatment for pica and rumination. Hopefully we get to the rumination. If not, that's okay. It's kind of a different kind of food selectivity. Pica is eating the wrong stuff, and rumination is eating the same stuff over and over again. Before you get too judgy, there's always been a period in our lives where we put the wrong things in our mouth. And I always like baby pictures because I think they're clinically fascinating organisms. Pica is compulsive recurrent consumption of non-nutritive substances. That's kind of a technical definition. More functional definition is swallowing inedible items. And people have come up with really fancy terms on the different types of things that people have swallowed. Acuphagia, sharp objects. I'm not even going to attempt to pronounce all of these: laundry starch, burnt matches. And at one point or another, I've run across folks that have done just about everything there. I have to admit I've eaten raw potatoes myself. And it goes on to another longer list. I haven't found a name for wasps, but when going through the research, one individual specifically ate live wasps. And fortunately, the treatment panned out well for that. The etiology can be nutritional, iron and zinc deficiencies. It's also been found at increased rates with ladies who are pregnant. The mental health aspect of it, OCD, anxiety, schizophrenia, and depression, and also sensory stimulation, automatic reinforcement, and also social reinforcement. A lot of health risks associated with eating things that shouldn't be eaten. Toxicity with lead poisoning, parasitic infection, getting worms, malnutrition, not eating nutritive substances. Also oral and dental health problems, obstructions and perforations, which is the one that gets folks most excited, especially with metal cans, the different things, sharp objects that people can eat. One individual that will be reviewing in the case study, specifically metal. I've also worked with an individual who swallowed a metal can. Surgery is involved in taking it out, and it can cause some real problems. Also, the risk of harm from finding items, and that's running into the street to pick up an item or eating lit cigarettes. treatment for pica, again, is well established in the behavioral literature. Reinforcement procedures are common, response reduction procedures, response blocking, effort manipulations, punishment, combination procedures, environmental prevention, removal of potential pica items from the environment, restricting individuals' access to certain environments, and also using restraints, helmets with masks on them, hard plastic gloves so they can't pick up items, arm splints I've seen so they can't bend their elbows to put anything in their mouth. And pica exchange, which is essentially amounts to discrimination training, teaching the person what is edible and what isn't, and trading the inedible items for the edible items. And that's the two cases that I'll be going over today involve pica exchange. Here's two individuals that I worked with before, 46-year-old male. Both of them had profound intellectual disabilities. And at the time of the study, they were 46 and 27, and the DSM-4 was in place, but now DSM-5 and most of these diagnoses carried over, and both of them had lived in the institution since they were 6, 7 years old. These are really neat guys. I can't, when I look at this just kind of strips them of who they are, but real interesting guys. They had lives, they went out, they worked in the community during the day, and were just real enjoyable to spend time with. And I always hate stripping it down to just this diagnosis and their age. Dr. Gonzalez mentioned working with the team, and we've got thorough consents and approvals with the guardian, the physician, the dietitian, the behavior management committee, which was made up of behavior analysts, licensed psychologists, psychiatrists, the human rights committee, which were made up of community members. I think there was an attorney on there, family members, but got approval for all these procedures prior to beginning them. The first case, which was the 46-year-old individual, and pica was defined in his case as swallowing inedible objects. We were more targeted on pica attempts because of the danger involved in eating the metal, and that's placing inedible objects to his lips. We didn't even wait for it to get into his mouth. We just scored and intervened at that time. The x-ray data was the most interesting. We had access to the records and went back 20 years to the mid-80s, and in just about every x-ray taken at least once a month, we found screws, bolts, zipper tabs, pop tops, staples, nails, all kinds of metal objects in his x-rays. And there were a couple of times where he did need surgery to get things removed. One time he inhaled zipper tabs, and they were going into his lungs, so they had to go in and remove those. This is just a snapshot of the items that were found in his x-rays over about an 18-month period. And anywhere, some months there wouldn't be any, but there'd be as many as 10 or 11 items in the x-rays just during this period of time. Further back, some of the months had over 20 items in the x-rays. And these are the pica attempts. Again, we didn't measure pica, we wanted to measure pica attempts during the same period of time. And it looks like it's on a downward trend, but still, with the items that he was eating, and these were all interrupted events of pica, he still was doing it frequently enough to be at a danger. When you lay in the x-ray data over the pica attempts data, we weren't catching all of it. The red line is the pica, the metal items in the x-rays. So it was happening a lot, and it basically came to the point we had to shut this down. This had been going on too long. The risks were way too high, and had to draw a line in this sand. So he was put on arm's length, one-to-one supervision around the clock. So when he slept at night, there was somebody sitting right next to the head of his bed. His living room and bedroom were vacuumed 3 times a day. When he went out to work, he would get on a van to go out into the community, and they would refresh flower pots around town. The van he got into was vacuumed, and he took his meals in his living room rather than going into the dining room, so we limited everything down. And when he was out in the community outside the van working his job, there were 2 staff with him. And all this was done, first we wanted to shut it down, but it was highly restrictive, and you never want to do anything that's highly restrictive and just leave it that way. Our plan down the road was to reduce the restrictions so he could get back to a full life. After we shut down the environment, we continued with some PICA exchange sessions, but then focused in on them more. And what a PICA exchange session was, teaching him what to eat and what not to eat. One staff would sit at the table. He would sit at the table with them, and the staff person would lay out 10 inedible items and prompt him to pick up the inedible, hand it to him, and he would get a preferred edible item. Second person sat right at the table with him, should he go to put the inedible item into his mouth, to block the attempt and prevent it. These were assurances that were put in place so that all the members of the treatment team were comfortable going through this. And a lot of preference assessments went into this to identify what he liked. We used the raised reinforcer assessment of individuals with severe disabilities that Fisher, Piazza, and those folks did to identify all the items that were preferred for him. Then we tested those items using the paired stimulus preference assessment, which is Piazza, or Fisher and Piazza, Bowman, and those guys from 1992. And then did another set of preference assessments to test that using multiple stimulus without replacement, the De Leon and Awado study. And once he consistently traded with the person across the table, then he would trade items with the person sitting at the table with him. Then he would have to get up, walk 5 feet away, trade with another person. When that was consistent, walk 10 feet, trade with somebody, to get him to where when he found something, he would just take it to somebody to trade for a preferred edible. Then went to trade with somebody standing at the door. We also, throughout the day, the technicians that were with him would work with him. If he picked something up, they would also trade with him. And so we wanted to make this just an everyday part of his day, and started very small and worked through his environment. And this is just a snapshot of about 5 months of twice-a-day sessions of doing the PICA exchange, of teaching them. And as we faded further and further into the environment. And then throughout the day, this is throughout the day data of how many times he would pick up and do the PICA exchange outside the PICA exchange sessions. We did want to generalize it. There's 3 lines of data here, and the first one is when the PICA exchange was initially starting out. The little pink lines was pressure from the Department of Justice. They wanted us to collect data differently. We fought it, but you can't fight them because it suppressed the number of independent exchanges. And then after they weren't around, we went back to the old way of taking data. The decrease isn't so much a matter of him, the procedure not working as well, but he stopped picking things up. And so since there was no opportunity to engage in the PICA exchange throughout the day, he just didn't take the opportunity. Then I'm going to go back one slide. You can see this took a few years to get to the point where he wasn't picking things up, and we were reducing the restrictions. He was freer to go around into his environment some more. There wasn't somebody arm's length from him going into different parts of his home. But we wanted a test. We wanted to make sure that that he truly was not picking items up. And so we wanted to test him, and we wanted to test him with metal items. So during regular leisure time, we would put metal objects within 10 feet of him and see what he did for about 10 minutes. If he picked up the metal item, he was prompted to trade it for a preferred edible. If he didn't pick up the seeded item after 10 minutes, he was prompted to pick up the item and trade for it. And the primary care physician initially approved a dime or a nickel. We could put a dime or a nickel down for the sessions, and she at this point had more confidence in the program than we did. We just put down a dime, and then after 60 sessions of this, either in his living room or out on the porch, the primary care physician said, "Oh, put some quarters, some nuts, some bolts out there, see if he'll pick those up." And these are the graphs. Essentially, he never picked anything up. And so the first phase are when we put the dime down, never picked it up. The black arrows are when we were doing it out on the porch. And then we started using a bolt in the living room and out on the porch, and he still wouldn't pick it up. So at the end of the session, we'd prompt him to pick it up, and he would trade it in for an edible item, and then we went to 2 bolts. By then, we were pretty satisfied that he had learned to discriminate and decrease the pica. And this is the original baseline that we had in the earlier slide. And then once we added in the treatment, the frequency of pica attempts went way down and consistent for about 5 years. This is the original graph of metal items that we found in the x-rays. And after we started the treatment, we went from October 2003 through June of 2011. Every time there was nothing in his x-rays. So we were pretty confident that we had an effect here, and quite pleased with it. The second individual, and this one's a lot quicker, we were running these 2 concurrently. There were actually a couple other individuals we were running pica exchange programs on, and they went well, but this one shows in a little more detail the progress of the pica exchange. This individual, his pica was swallowing inedible objects, and his pica attempts placing inedible objects in his mouth without swallowing them. He ate grass, little pieces of paper, little pieces of cloth, not as harmful of materials. And if he did get something into his mouth, we could ask him to take it out, and more often than not, he would. So his pica attempts definition was a little looser. And here's more detail on his pica exchange, where he's sitting at the table twice a day with a technician and trading an inedible item for an edible item. Then 5 feet away, did it consistently. 10 feet away, did it consistently. When the person went to the door, he was fairly consistent. Then he got a little distracted, but then back into it. And so he was consistently demonstrating that if he found an inedible item, he would go to somebody and turn it in, basically. And these are his independent exchanges throughout the day for the generalization checks. And these are his pica attempts for about a 4-year period. And again, these are attempts. They were easily redirected. And we felt we had a pretty good effect of decreasing his pica. And so here's a pause. If we have time, we can talk about rumination next, but does anyone have any questions on the pica?
Yes, we do have time for questions. So if anybody in the audience has a question, please feel free to unmute yourself in the lower left-hand corner, and you can go ahead and ask your question now.
Hi, Joe. This is Michelle out of Kentucky, and I've worked pretty extensively with quite a few pica cases, and especially in the institution setting. How did it go with your LOS fading? Did you successfully get him off of the one-on-one, and did that impact your intervention at all? Did you have to slow down or change?
We did it very slowly, and no, it didn't impact. The arm's length was dropped, and it was a very loose one-on-one. The staff person wasn't right with him the whole time. He was just pretty much in an environment with other people. And it wasn't real apparent that the person assigned to him for the day was assigned to him. They were just there in the environment.
Perfect.
Thank you.
Thank you so much. And I would like to pass it really quickly to one of our panelists, Zoe McGale. Dr. Darling, do you mind unsharing your screen so we can view all the participants during this discussion part?
I will do my best.
You've been doing amazing with the screen sharing in Zoom. So,
Hang on.
and Haley, please feel free to jump in and share with us how you can unshare.
There we go. Okay.
Nice work.
Great. This is Zoe Miguel, and again, I'm a licensed clinical social worker from Santa Fe, New Mexico. And first, I wanted to say thank you so much for this presentation. PICA comes up often and is scary for many folks, and so I appreciate it a lot. So as I said, I'm a licensed clinical social worker, and so oftentimes in my community, PICA is approached from a psychosocial perspective. I think, just again, my preference is always to have a BCBA, a behavioralist, because I think that intervention is highly effective, and the psychosocial approach I don't always see as being as effective. So how would you encourage, social workers, psychologists, those types of folks to to connect with a more behaviorally based person, specifically if they're not in the community? Are there institutions? Are there more sort of national organizations that we might be able to access?
To find a behavior analyst?
Yeah, or to find somebody who could support the intervention from a more behavioral perspective.
I would hope most behavior analysts would know something of this area. To be honest, no, I don't know of any like PICA organizations or behavior analysts that do this. And when I go through the literature, checking the names of the people, I like to read the reference section of an article and know who those people are and find out where they are. And that'd be a good place to start on, well, who's doing the PICA stuff? Who's really good? And oddly enough, whenever I approach these people who publish in journals a lot, they're really nice, more often than not. And they're willing to at least email.
Brilliant. And Joy, this is a question for you and Kathleen. Is that something that folks could refer to BCI for, or to another ABA program?
Yes, absolutely. So Behavior Change Institute, another organization. But yes, from the behavior analytic component to seek out that piece of it, absolutely. And then hopefully that's part of the mission of ECHO, is to identify how we can coordinate care with other provider types. And so if the behavior analyst doesn't have that knowledge and expertise, learning how to reach out to these other community providers and connect and form these partnerships. Because what's wonderful with what Dr. Stoll does here at the Thompson Autism Center and our presenter, Dr. Melissa Gonzalez from Kennedy Krieger, is they have these core teams that they're already able to tap into. And so for this piece of it, when we're working in a rural community, we do primarily, ECHO Autism is primarily serving the state of New Mexico, although many of you are joining from around the country. And the goal is to reach providers that are in rural communities and underserved communities. And so how can we help you all learn how to connect with resources? And I think Dr. Darling's suggestion was a great one, and something that I feel like we've learned as a community through these interactions with Dr. Stoll as well, is that these people want to connect with us, and they want our knowledge as well to be a two-way street.
And I wanted to, if I may, to just circle back to the earlier presentation, and maybe Dr. Darling, you can speak to this as well, is that the impact on the family that eating difficulties is profound. And one of the things I've been lucky enough to collaborate with other teams, ABA teams, and one of the things that often comes up is the family's history, either in terms of culture or an individual's history, can really affect the outcomes of an intervention. So an example of that is I was working with a family, and the child had some pretty severe eating aversion, and the mom had significant trauma in her background. She had spent much of her childhood starving. And so that was really important to deal with that piece for mom so that she could come to terms with her history and her trauma in order to be able to support her child. And so I think that piece of collaborating with mental health providers to provide that support and really actually to do some psychosocial history finding when we're approaching something as significant as a feeding issue. Dr. Darling, do you have any piece of that you would like to add, or any insight?
To be honest, no. You really have to work with everybody in the environment. You're not just working with an individual. It's got to be everyone in the environment, and knowing their history and what brought them there, because especially if they're going to be supporting the treatment as the person leaves wherever they are, you have to know, are they able to carry it out? Are they willing to carry it out? Are they motivated to carry it out? And do they understand the importance of it?
Mm-hmm. Thank you. Thanks so much. I appreciate the opportunity to both share and also gain expertise. I really appreciate it.
Thank you so much, Zoe. And I think you brought that back very nicely to being able to coordinate that care and the importance of it as well. What I would like to do is we have one more case presentation that Dr. Darling has on rumination, and basically the entire time we're sitting here, Dr. Solo is going, this is so cool. And so we need to make sure that we get through that, and we're going to have time for additional questions at the end, but I would really like to make sure that we're able to hit the second case study, and then we'll have some more discussion.
Rumination. The technical definition is repeated regurgitation, chewing, and reswallowing previously ingested food. The etiology: food allergies, infections, hiatal hernia, medication side effects, esophagitis, medication side effects, and automatic reinforcement. And one of the things that I've read in the literature and has been hypothesized is it often will start with a medical issue, and the individual finds it reinforcing, and they learn how to do it at that point. And they're able to bring up food and enjoy it over and over again. And that's where the intervention comes in. The health risks are the electrolyte imbalance, the weight loss, esophagitis, esophageal cancer, and respiratory complications. And it's estimated that rumination will be the cause of death for 10 to 15% of the individuals who ruminate. The treatments were real interesting going through the history of it. Loving Care, I just like the name of that. I don't think it was very effective, but I liked it. Electroshock, on the other hand, I didn't like that, but you can see this was 67, 68, and again, this is a life-threatening behavior, and it was necessary to stop it right away. As time went on, less aversive interventions, aversive taste, lemon juice, cayenne pepper, contingent on the occurrence of rumination. Pinching was effective, oral hygiene punishment, having the person brush their teeth afterwards, and also contingent exercise. Extinction has been shown to be effective. One would have to assume that there's a social reinforcement component functioning there, differential reinforcement, and dietary manipulation. And that seems to have been used quite a bit, increasing the fibers, the starch, or just increasing the entire meal. Also liquid rescheduling and That's waiting a couple hours after the meal before drinking anything. Peanut butter has been shown to be effective, and a couple studies using white bread at the end of the meal. And so that's what we did here. This is the second participant in the PICA study, but wanted to use the Thibodeau, Blue, and Reedy and Lucelli intervention of using slices of white bread. So we got 5 slices of white bread at the end of the meal, broke them up and gave them to this fellow, spaced out over 20 minutes, and didn't use the procedure after every meal, but on the average about 6 meals a week out of the 21. And again, we went through the full approval process to make sure we had everything balanced. And when it came to the rumination, medically they had done everything they could. And we had the same primary care physician throughout this whole procedure, and she'd been with this individual for a while, so she knew the case and knew this was going to be a safe intervention. The dietitian wasn't too happy at first. She took a little more convincing that this wasn't some crazy intervention that we just pulled out of a hat. But showing her the research, she says, okay, give it a try. But she was concerned with the potential weight gain giving somebody all that bread. And these are the baseline data, the average percent of rumination, and it runs about 15-20% of the time. And again, the rumination occurred primarily when we did scatter plots, an hour after breakfast, an hour after lunch, and an hour after supper. So that's where we did our sessions, and it was actually highest after lunch, and we would ran 3 sessions of baseline and measured the frequency of rumination, and then spaced out, offering him bites of bread over a 20-minute period. And it came down during the lunch sessions. And again, we're just doing this 6 times a week. Supper was the second highest, and we were able to reduce the frequency of rumination a little better in those sessions. And this is actually a multiple baseline design. I didn't put it all on one slide. And breakfast was the lowest, and we intervened there last, so it was going along fairly well. And so we trained 2 of the technicians to carry out the procedure. One staff from the day shift who would carry out the procedure at breakfast and lunch, one staff from the evening shift who would carry out the procedure at supper. So after we demonstrated that it was an effective intervention, and they were randomly assigned to the supervisor to assist this individual during his breakfast, lunch, and supper. And the procedure continued to be used 6 or 7 times each week over a period of time. And this is back to the all-day data broken out by meals. And over a period of time, we demonstrated its effectiveness in sessions, then carried it over to the technicians who did it throughout the week on different days. And then over time, it continued to go down and go down. And during this period, his weight fluctuated during the whole 3 years of this between 140 and 150. So there wasn't any, the dietitian was very satisfied that it didn't cause any excessive weight gain. And the rumination decreased, so everybody was happy. And that's the last slide. So any questions?
Okay, great. Kathleen, I would like to move on to you then from our panel. And if you have any comments, do enhance the learning opportunities or questions.
Great. Thank you so much. I do have a question, Dr. Darling.
wonderful job. This is so fascinating, and we're so happy to have you. I did have a question. In both cases, you mentioned consulting with the Human Rights Committee, which I think is really fascinating as well. And because the whole concept of our ECHO is to learn how we can better coordinate care, I was hoping you could speak to how you got involvement from the Human Rights Committee and how you approached them.
It was handed to us, to be honest. There was a standing Human Rights Committee, and it just seemed right to take anything different and let them look it over, since these were members of the community. Now, I work in a more community-based setting now, and we've developed a Human Rights Committee, and we just kind of go out and ask people that we come in contact with that might have some interest, hey, would you be willing on a regular basis to come and look over what we do and make sure we're not doing anything questionable from your perspective. And so anybody that has an interest, they don't even have to have any expertise in autism or developmental disabilities. But I think it's good for an organization to bring people together from the outside just to look over things.
Absolutely. Thank you so much.
Excellent. Yes, and I completely agree that it is very beneficial and important. There's an organization that we actually work with quite frequently, and they have created a similar method where they have a Human Rights Committee and a Behavior Intervention Committee, and they actually bring in individuals to consult on their cases. They meet once per month. They review cases for these purposes exactly. And they do so with individuals that are outside of their organization. So the organizations will actually team up, and then they'll review for one another and have really been able to enhance the services that they're providing while ensuring that they are maintaining the rights of the individuals that they're working with. And this is with an adult population. So I think that that's great that you were able to bring that piece in, Dr. Darling, as well. What I would like to ask too is, do you have anything that you wanted to add?
You know, a lot of what I talked about earlier, I think is probably some of the most important things, but I think that for me, it really was fascinating to hear both of the cases because I deal with a lot of little children, and as they get older, obviously, then I still continue to take care of them, but these are very extreme issues for families, and I've had many, many young children have extreme pica, staples, you name it, colds, all that kind of stuff. And so one point that I wanted to make was that, and this kind of is what made me think of it, so and this is what I love about this interdisciplinary thing, so as soon as your slide popped up of all those x-rays, I was like, oh, his cancer risk is awful. And so these guys were like, oh, I didn't think about that, but that was my immediate first thought, like, oh my goodness, the amount of radiation this gentleman has had is putting him at significant risk for cancer. So when we think about how all these things fold in together, we also can't forget that these people are people. And so thinking about, well, okay, yeah, he swallowed a bolt, he swallowed this, and yes, we need to know, and where is it, and all that kind of stuff. But this brings back home how crucial it is for us to not only understand the stress it causes the family, the difficulty it causes for the individual with autism, but then also the lifelong potential consequences and medical comorbidities that happen as a result of these things. And so that just struck me because I thought, wow, that is really interesting. And so you can see similar issues with constipation. So again, just more ways for you to kind of advocate. And then, you know, knowledge is power, right? And so if you're taking care of a kiddo who, I don't know, has pica or has severe constipation and they're getting regular x-rays for that, obviously I don't advise calling the doctor and telling them what to do, but at the same time, you know, we do want to make sure these kids are not getting unnecessary exposure to radiation. It is a big deal. It is a real risk. So I just love, that was such an interesting thing for me. So my biggest thing was, yay, he didn't look like he was getting all those regular x-rays. So that made me feel much better. But just something for you guys to think about too, as far as long-term consequences of these behaviors as well.
Thank you for bringing that perspective in. Dr. Darling, I wanted to ask you a quick question regarding the team. So we talk a lot about the care coordination and the consultation with other team members, And I was hoping that you could discuss a little bit more about your team. I know that you had a PCP that you were consulting with, as well as a board certified behavior analyst, doctoral level. Who else was comprised on that team?
Dietitian, licensed practical nurses, registered nurses, case manager. We also actually had physical therapists and occupational therapists on the team. They didn't really have much input, but they were there. Licensed psychologist. I think who else was there? We also, and this is a really important thing, is the technicians themselves. When we had those team meetings, having their input was critical because they knew the people we were working with.
Absolutely. And I think that this is such a wonderful example that piggybacks right off of what Dr. Melissa Gonzalez was speaking about during her presentation. So that's a great example. And I'm so pleased that we had the opportunity to pair her presentation with these case studies today because everything has just aligned very nicely. One of the things that I wanted to just make sure that I shared is when we go back to the care coordination role and how we've discussed our role as behavior analysts when we're seeking out these consultations, and I think that Dr. Soul did a nice job and actually always does a nice job, and I was telling her of humanizing pediatricians and primary care physicians that we work with and feeling more comfortable being able to approach them, but also thinking about resources that we can bring to the pediatricians when we are reaching out. And so there are some toolkits. There's one from Autism Treatment Network that Missouri specifically is one of the partners that is for medical professionals, specifically to help them learn a little bit more about PICA. So we'll incorporate and include that within the resources on Box, as well as a few other toolkits that are meant for parents. And it might be just a good opportunity for you to look at utilizing those within any cases that you might have that are when you're trying to educate parents as well. So we'll just put those in as resources for you. Then the other piece as well that I thought was a good piece was also just not assuming that once the child has medical clearance that they're good to go for the entire duration of treatment, but continuing to monitor and noting if there are any changes that are occurring and then going back to that PCP and bringing up those other symptoms or behavioral indicators so that you can bring those additional concerns up if that does seem to be pertinent information, so you can help guide that process. And then the last piece that I really wanted to say is that I think it's nice that we had this opportunity to see these two particular cases that Dr. Darling presented. It's an opportunity that not everybody gets to be able to see these types of cases. And within the practice of behavior analysis, it's not always the opportunity to contact the different intensities and levels of intervention. So that is exactly what ECHO Autism is about, is to provide you with these opportunities to contact cases that you might not otherwise contact within your career, or it could be 5 or 10 years later. So we really appreciate you being able to come and present today, Dr. Darling, and thank you.